Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Welcome to the Mad in America podcast. My name is Brooke Seam, and I am the author of May Cause Side Effects. Today, I am with Dr. Rodrigo Nardi. Dr. Nardi is a psychiatrist and psychologist. He obtained his psychology degree in the year 2000, and following that, he obtained a certificate in CBT and a master's degree in clinical psychology at the most prestigious Brazilian university. He obtained his MD degree in 2010, and in 2016, he completed his psychiatry residency at Penn State. Altogether, Dr. Nardi has worked as a mental health professional for more than 20 years, covering from individual psychotherapy to inpatient and outpatient psychiatry, substance use treatment, and interventional psychiatry. His passion for teaching and learning has led to the creation of the True Psychiatry Network and the development of a mentoring program designed to address the most frequent challenges related to psychiatric training. Dr. Nardi, thank you for being here.
Thank you, Brooke. Thank you for having me. It's a pleasure. It's really a lot of fun to see you again.
Yes, it's good to see you too. So your bio, is where I want to start because you have a bit of a circuitous route to becoming a psychiatrist. Can you tell us how we got there eventually?
I always say that once you start studying psychology, it doesn't matter how much you wash it, it's not going to leave your skin. Because you see in Brazil is a different system. It's more like the European system. So psychology is a full grad school. It's like 5 years studying psychology. The last year you work as a psychologist under supervision. And medical school is like that, 6 years, and the last 1.5 to 2, you work as a doctor, you perform surgeries and do all kinds of things that you have available, and you do that under supervision. So then once you're out, you're ready to work. I finished psychology and I started to work with a particularly inspiring guy. He was an oncology doctor. And meanwhile, I got that certificate in CBT, and I was, in those years, I was like a radical behaviorist.
What is a radical behaviorist?
Well, basically, Skinner was the top brain in psychology for me, even though you go through the tests and exams and learn Freud and Jung and everybody else involved in this beautiful history that psychology has. But I was a Skinnerian, so I had a CBT certificate, and after that I got into a master's degree with a behaviorist mentor. But before I finished my master's, I said, okay, man, I think I'm going to go to medical school. And then I started all over. I started all over again. When I was in medical school, I was teaching psychotherapy techniques to postgrad, and I was assistant professor. And for a short window, I thought I wanted to be an oncologist. Because in Brazil, family practice is very strong, the training in family practice. Every year, we had to do some sort of data collection, some sort of small research. And I would tell my colleagues, because I was older, I was used to the whole writing and collecting data. It was kind of effortless for me by that time. I would say, okay, leave him. I'll do it. If there's a task that is kind of more boring, you guys handle, I'll take care of it, because it was like a team kind of a task. I did behavioral-based questions. And I was like, what's wrong with me, right? I could look into anything, but I couldn't get rid of this psychology thing. And it dawned on me that once you go and you read something in depth, once you connect with a school of thought in psychology, your view of the world, everything, it changes for good. So when it came to choose a residency, I just could not prevent. So I applied for psychiatry, and I was lucky enough to get in a position. And I was lucky enough and I'm going to tell you, it was a fun ride. It's a wonderful career, despite the limitations we have, or despite the excesses of the field. It's a beautiful career. It's a lot of fun.
Given your background in psychology, what was your view and mentality going into the psychiatry arm of medicine at that time?
On account of being a behaviorist, on account of being a psychologist, the biochemical hypothesis never made any sense. It could not make sense. If you read any author in psychology, that argument will die. Even I can entertain that maybe 1 in 1,000 people presenting with low mood could have some biological issue, just like every other organ can fail. I never bought into this thing. But going to residency, it's a very humbling experience. It doesn't matter. How can I make an equivalent? Imagine this. Imagine that you're a black belt in karate and you're going to start jujitsu. You're a white belt again. Nobody's going to listen to you. Fair. So it was, of course, I wasn't a black belt in psychology. I was at best capable of a fair amount of effort. I was never very talented. My development as a therapist is still going because it's a very long art. But then what you do is you say, okay, we have this data saying that the meds cut, right? They do something. So I think I can manage to live that split inside my head, right? Even though it didn't make too much sense, but there was a lot of questions, right? But it was difficult for me because it's a funny thing. Everybody knows of the influence of pharma on the training, on the textbooks, on the overall paradigm that psychiatry has. Everybody knows about it, right? If anything, people say, well, I could get a grant for this research, I could get a grant for that research. Actually, people gravitate towards thinking of research questions that could find a grant with pharma companies. It didn't occur to me that I was blind like everybody else. And I'm a big fan of human beings. I'm a huge fan of human beings. I think we're the most amazing thing walking on earth. But I think I was also naive. I believed the integrity of the process. And obviously, I woke up to that a few years later.
We are going to get to that for sure. Before we get there, I was listening to an episode of your podcast, the True Psychiatry podcast, in preparation for this. And I believe it was the episode where you were talking about pediatric bipolar. And you said something that really stuck out to me, which somehow this has not dawned on me in all of my work around, this subject. You said that doctors are very good at memorizing, and that when you're going through med school and residency, you don't really have time to be a critical thinker when it comes to the information you're receiving. And that was such a light bulb moment for me, because I keep, I'm not an MD, and so I keep trying to figure out, why does this compass almost get so far off course? And I think this may have answered a little bit of that for me. So can you talk a little bit more about what it's like to be a psychiatric resident and what you have to do in order to make it through that training that then might be influencing the situation we find ourselves in today?
Medical school and residency, they are a compliance task. For example, if you go through medical school and you decide to question everything you see in front of you, not only the emotional impact prevents you of learning, I know that for sure. And I know that for sure because in Brazil, the training in psychology, for example, is very different from the American one. We still have, when you get together during the intermissions, there's still the clique of behaviorists making fun of the clique of Freudians who make fun of and that is an important learning experience, because the Freudian is going to look at you and present a criticism to Skinner, and you have to freaking work on it, right? So at the end, psychology in Brazil is a very strong science and art. We have wonderful thinkers. Every average psychologist can sit and give you a class on something immediately that will be at a postgrad level. Anyone, I assure you. It's very strong on account of that kind of a battling on, my theory, my thinker is better than yours. That's mumbo jumbo, my science. And the other one says, well, you think everything is measurable. Anyways. It's a funny thing because after 20 years of studying this thing and going through Freud with some degree of depth and Jung and Maslow and evolutionary psychology, even though I'm not an evolutionist myself, I can tell nowadays the amount of overlap and similarities, it's actually larger than the discordance. And that changed my life completely.
It's like religion.
Well, yeah, you know what? It is a fair comparison. But when you look into, for example, Freud's civilization and its discontents, when you look into Jung's suggestion that life has to be a quest and the need for meaning, when you look into Maslow, when you look into positive psychology and evolutionary psychology, and you freaking read the Bible if you want, you find so much overlap that I'd say, you know what, I can make something out of it. And that is actually part of the mentorship program, the overlap between those arts. But anyways, what I learned in psychology is that if you don't have an emotional affiliation to what you're reading, your retention and understanding is much more limited if your mind is not open to it, right? So when you take that concept and you put into a medical school that has a very heavy load of hours and content and tests, really, if you don't embrace what you're reading, if you don't comply with it, you will struggle with your grades. There is no time to actually look into all these things and question every bit of them. And, medical school has the excuse to be very basic, good part of it until you get into the specialties. But then you get into residency. In residency, you have a set system based on a set paradigm that is heavily biased and a limited amount of time to learn those things. You have to apply whatever knowledge you have and present to an attending. So the attending has to, you cannot go and present a critical statement saying, listen, like one thing that I realized is if I suppress the negative emotions of these patients with drugs, what motivation will this patient have to address his own reality? In residency, I was absolutely immersed in this thing. I was like, okay, I got to go and I have to please this attending. I have to look smart to him according to his book of rules. So as a result, I left training being a very heavy, because I'm very passionate about this whole thing, and I was already. So I was a heavy guideline kind of a guy, but I was still blind to the absurd amount of bias we had. That obviously became very clear later, and kind of triggered my quest for an alternative paradigm of psychiatry that could survive in our society.
That is where we're going to go. But first, can you tell us where did you go after your residency was over? What did your practice look like so we can get a little bit of a before and after idea?
My first job was inpatient psychiatry. And it's a funny thing because I was seeing excesses, medication regimens that couldn't make any sense. But what I was telling myself was, okay, this is inpatient psychiatry. Of course, I'm going to see very heavy meds because in patient psychiatry, after all, people are refractory. That's refractory, I had this idea, and, you kind of push away when you have thoughts like, oh, wait, what's the point of giving a drug to solve a problem that is a quality of life problem, for example? But you keep pushing. And then when I left inpatient psychiatry, where was this environment where I had some sort of cognitive trick to tell myself, yeah, there must be a reason for this mess, for all these medications mixed together in this reported pile of diagnoses. From there, I went to substance use, but that was outpatient. So then I started to see all these patients talking about staying sober, being prescribed Adderall chronically, benzodiazepines chronically, gabapentin chronically. And then I said, no, there's something wrong. And I would have patients come to me and say, Rod, please let me see you, because Dr. So-and-so prescribes the same thing to everyone. Like everybody has ADHD, everybody has generalized anxiety. So everybody ends up in Adderall, gabapentin, or Adderall and benzos. And they say, and I'm really trying to stay clean this time. I heard from patients say, don't believe for a second that people are looking for gabapentin for anxiety. It's to get high. I heard that like a handful of times. And I started to notice there was something wrong with it. And that generated enough anxiety on me. And I was so displeased with it because, when you in the outpatient setting, you were inheriting so many cases. And I started to feel my profession sucked. I was teaching Psych and P in those days, and she was shadowing me, and she said, Rod, you should do something about it. Like professionally, you should have like a mentorship or something. So I started, my first idea for the mentorship was actually a heavy guideline. I said, if we embrace guidelines, the excesses will go away. I was still blind. When I finally started with the podcast, I also started kind of smooth. Let's go easy. Let's just talk about what makes sense. Talk about psychology a little bit. But then I started to find literature like from critical psychiatry, from Med in America, and I started to learn from those folks, before I even contacted them. And that for me was like a shock. And then I said, oh my God, how come I didn't see these things before?
How did you find, the work of Whitaker and whatnot?
I think Whitaker was a key person in that sense, in opening my eyes. I think Ron Bassman and his experience with psychosis and the system back in the 60s and 70s, that was also a key thing. And when I started to hear them, I was like, wow. So those things started to fall in place for me because I was slowly moving there. And I felt terribly anxious and angry for being blind to those things. So then I really started to dive deep in the whole, what can we call it? I don't have a name for it. I feel like, okay, we're going to talk about, we could call critical psychiatry, but you see, I learned a lot from those guys, but I also keep a respectful distance on account of philosophical differences. And political differences. So one of the things, I don't know if you remember, one of the things I have for my podcast is I never talk polarized politics because it makes no sense that reality, so complex as it is, could be explained by one side or the other. So I don't know how to call this thing that we have. I decided to call it True Psychiatry because I love psychiatry for the good it can do. And my motivation was to save it as opposed to destroy it, So even I spoke to people and I learned from people from critical anti-psychiatry movement. I also, I learned because I can learn from anyone. It's just one of those traits that I was blessed enough to have. But I'm not anti-psychiatry. I just want a grounded art. That's all I'm looking for.
When this transition was happening for you, what was your relationships with your colleagues at the time, and how did that start to change?
I remember a director telling me one day, he said, you have a fiduciary duty to your patient. Even if your employer is a place that takes Medicare or Medicaid money, that's tax money.
Why don't you explain what fiduciary duty to your patient means?
Well, meaning who's paying you is who you're serving. And we serve patients. We don't serve the hospital. You don't serve the clinic that hired you. You don't serve your CEO. You serve your patient.
You don't serve the pharmaceutical company who might be paying you on the side.
Perfect, right?
What do you think makes you different in the sense that why were you willing to go toward the discomfort and look into it, whereas so many other folks in the field seem to just go immediately to defense?
I think I'm just another one that feels like that, to be honest. I wish I could think I'm like some sort of messiah, and my ego would want me to feel special, but I have to be honest with you. I have seen Psych and Peace quit after all the training and go back to a registered nurse profession because they could not live with what they were forced to do. Massachusetts is a particularly, let's call, polypharmaceutical state. And I saw professionals there just saying, dude, can't do this anymore, So I guess is if you like what you do, and I do love it, you don't want to see corrupted. So in a sense was also selfishness. I said, listen, if we can develop a way to work that brings me more satisfaction, if I can develop a paradigm that can survive nowadays, considering the legalities of it, and have much more fun I think my life is going to be better because I had a job where I inherited, and I was a director and I couldn't make a dent, to give you an idea, because the structure was so frozen in that concept.
So walk us through what you're doing differently. And also, if you could kind of just give us a general outline of when we're talking about standard of care in psychiatry, what does that mean conventionally? And how are you managing the tricky line of still making sure you're meeting standard of care requirements while operating in this alternative paradigm?
So one thing about standard of care is this, because of the significant, let's say, litigations, the legality involved in the practice of medicine, people feel afraid of doing anything differently because having bad results is unfortunately part of the art
of medicine.
Yes, art of therapy, art of medicine. That's also an interesting discussion. Is medicine an art or a science, right? Applied science? Well, it seems to be both. One of them, the easiest step towards it is the informed consent. You see, in psychiatry, informed consent is really not performed. Let's call traditional psychiatry, right? The psychiatry that we know of. I started this funny prank, so to speak, right? This joke with mentees and colleagues. I would say to them, would you take Seroquel, which is an antipsychotic, with all the set of side effects that comes with it? Would you take Seroquel if you were insomniac, anxious, or depressed? Right? Would you take it? Would you take Seroquel? Would you take Seroquel? I started to ask everyone. And not once anyone said, yes, I would. And then my next question is, well, why are your patients accepting when you offer them? And the answer is because an informed consent is not being done. Now, I'm not saying you should look at your patient and say, hey, I'm going to offer you this med because this is what my training is about, but I wouldn't take because of this. You don't have to put those words. You can just say, there's medications, an option. Here are the side effects that you can expect, the ones you would think of before taking a pill. And what I'm trying to say is that to have an informed consent, the patient needs to have a fair amount of information. And when you do that with any of the meds, any of them, you start noticing that about 8 to 9 out of 10 patients will say, let's wait another month. Let's see if I can actually address this problem with my wife, right? Things like that. I have a lot of patients that come to me, especially male, and say, man, I have a problem with anger. I have an anger issue, right? And what I do in my paradigm is, what I look for is what I call basic emotional needs. They're roughly, again, they're based in Freud, Maslow, Seligman, evolutionary psychology. And I say, okay, let's address these basic emotional needs, because they are basic emotional needs, if I can explain, they are linked to survival. All right. They're emotional needs, but they're linked to survival. And one of them is to have relationships. But what I find is people are terribly deprived of different basic emotional things that come right after in terms of relevance. And you're going to see how similar to Maslow this is. They come right after in terms of relevance to the physiological needs that life has. There's no point in talking about your mother in therapy before we address your solitude, before we address the fact that you have no accomplishments, before we address the fact that we human beings need novelty. We need new things, that we need to be pursuing stuff. And, this whole paradigm that I put together is an amalgamation of things. And there's like 1 or 2 pieces that are new, that are like my contributions maybe. And why do I say maybe? Because we live in a world with so many people writing and thinking about the problem. I wouldn't be surprised if someone says, hey man, I wrote exactly that. And one of the claims is that anxiety, in contrast with low mood and, for example, anger, anxiety is both endogenous and exogenous. It's both a reaction to environmental things, but also comes from the organism itself, just like sexual arousal is both, right? Because adds to your capacity to survive. Anticipating threats in the absence of those threats should be built in our biological system. But then I address those things. I tell the patient, let's work on these things, man. And I present my diagnosis in that sense. I still use the DSM because I need to pay my bills. I need to submit the charge. I cannot send a diagnosis yet to an insurance company and say, well, this patient is deprived of accomplishments, purpose, and social interactions, right? Which is also, very related to positive psychology. But, a lot of things of positive psychology are not really new. So I'd say, yeah, whatever DSM-ish form it takes, I'm going to put on paper. But I tell the patient, it's not something you have. It's just a name I'm giving to this thing. What you're struggling with is very basic things to have a decent life you don't have, brother.
I mean, that in itself, even just informing your patients that the name you're writing down for the cluster of symptoms, if you want to put symptoms in quotes, even just telling them that is such a radically different strategy, but so obvious and so basic than saying, oh, you meet the criteria for borderline personality disorder, or, what was it, bipolar not otherwise specified that you were talking about. And it's such a basic shift of perspective that can literally change the course of a life.
Yes. And that kind of information, it doesn't take so much more time than talking about drugs and anything, but it's so amazingly welcome by patients. You start seeing patients say, oh, I want you to see my sister. I want you to see my neighbor. They start sending referrals. So it's resonating. It's resonating with people. We are ripe for the change. And from a legal perspective then, because which is a simple thing, and you can tell I'm not being subversive. I'm just following the same rules that ended up in my textbooks. I'm performing an actual informed consent. And when I do that, the patient says, well, you know what, Rod, maybe I should address my solitude. Let's see how we go with that. Maybe I should do this. Maybe, let's address these very basic needs before we even consider the more elaborated things that keep people in therapy for life, or that are very specific to each human being. I'm still looking for the bulk of needs that would serve most people because the yield is unbelievably high. Quality of life, right? So that will be the first thing. Another thing, very interesting thing happened recently. I was interviewing Robert Haim Bellmaker and Pesach Lichtenberg. They just published what I believe is to be the most important psychopharm book of our time. I interviewed them, and I was telling them during the interview, because I use my interviews, because when you're developing something based on logic and you're doing things that are not testable, logic needs to be confronted. So that's one of the things that my podcast allows me, is I speak to the biggest brains in the world about this thing, and people that have interesting perspective, like was talking to you. I have to make a parenthesis here. When I asked you about grief, bereavement, and you said the most remarkable thing I never forgot. You said, I learned that bereavement will take its time and wait for you. Because my concern was, because I see that with substance use disorders. And if someone is on a binge, on a bender for 2 years, and he loses his mother in the middle of it, he doesn't cry, man, he's high. When he becomes sober, then he suffers. And I had that question about antidepressants as well, if they're suppressing your emotional experience. And then you write in your book that you're seeing colors differently, that you're having these sort of visions inside your head, that your creativity was actually burning somehow. I said, okay, I want to know if the pain came back. And then you dropped that bomb, and I was like, so allows me, that's, the podcast allows me to test all these ideas. So I always kind of drop a little bit of them, with very smart people. And one of the things I said was like, nowadays I can justify my paradigm in front of a judge, whatever happens, my practice. And as soon as I'm finishing that, Dr. Bellmaker said, that was one of the motivations for the book. Now you can show a judge and say, here, this guy with this CV wrote this book about psychopharm, pointing out what can and cannot do. And exactly for that. So it was like one of those goosebump experiences. It was a lot of fun.
I mean, I love that you that's something I said stuck with you. That is very gratifying. You know, we're not here to talk about me, but it's very nice that I'm glad that stuck.
Oh, no, and I have been waiting to tell you that all for a long while. I still talk about that with students.
Oh, that's great.
You know, because one of the questions is if what you're feeling, and I'm writing, right? I'm writing this paradigm. I'm putting it on paper. And it's not a final paradigm. It's just an alternative paradigm. Just like psychology has multiple paradigms, it just makes no sense that psychiatry doesn't have alternative paradigms of work. But I refer to emotions as our sixth sense, right? So what is the biological program that tells you to run if you see a grizzly bear? Right, which is useless. He's going to catch you, but it doesn't matter. What is the biological program that tells you, okay, you got to run? It's not just the sight of it. It's not just the smell of it. It's the emotional reaction that your body gives you to say, dude, this is the running type of emotion. And so emotions, negative emotions, they have an important role. And, you talk to a guy like Paul Andrews, evolutionary psychologist, he's gonna explain that to you beautifully. But basically, negative emotions have a role, right? And they're trying to tell you something about your reality, just like tight shoes will make your feet hurt. That doesn't mean your body's sick. Your body's working exactly as it should, right? Tight shoes, pain.
Right. We don't need a pill to make our feet smaller. Just need different shoes.
Exactly. But here's the beauty of it. Let's say you ordered those shoes. They took forever to arrive and they're just fabulous. You don't want it. You say, you know what? I'm going to go with it just tonight, just for the party. I look too good in them. I want to use them. What you do is you take a pill to suppress your pain, or you have a few shots of tequila. They're going to have the same impact of suppressing the pain, which is in this case, it's what I call a desirable impairment. Right? The price of going with those shoes, man, is worth it. Desirable impairment. You take a pain medication, you take some booze, whatever. So I don't rule out the possibility of a desirable impairment that suppresses emotions. But in general, changing the shoes, as you said, is a smarter idea. So what I learned from you with that statement about bereavement is exactly that, is that the feelings you have deserve to be felt. One way or another, there's learning there. They may be what pushes you towards, activity, connections, socialization, a new career. I know that part of my dedication to this maybe is too personal, but part of my dedication to psychiatry is the fact that my son lives in another country and I miss him terribly, and I have to find a meaning to his absence. So I use all this extra time that I have to make a sense of things, and trying to do something meaningful so I can, put my head in the pillow and die when I'm 80, look back and say, okay, I was not part of the problem. But that was meaningful for me because I look to my mentees and people that I work with and I say, listen, there's a reason for that pain. Some pain needs to be felt. It's not a disease. And if you suppress it now, there's a very good chance that not only you're inducing stagnation, which is the core of my paradigm, is that psychiatry, the role of psychiatrists is to foster movement. I don't want to induce stagnation with suppressing emotions. I also suspect that emotion is going to come back later for you.
So the nonprofit is the New England Psychiatry Mentorship Institute, and you said it's fairly new. Where do you hope this goes in the next 3 to 5 years?
So the mentorship I've been playing with it for about 2.5 years. So I started a private practice, and I have, limited amount of hours to put into this thing. And when it goes very well, and I said, okay, I'm going to expand it into a network. So it's sort of a cooperative. I'm going to teach the paradigm. It's an option. It allows for your artistic expression, so to speak, because that's what I believe psychotherapy is. It's financially sustainable. And I can do it in a way that is legally safe and safer for patients than, the excesses that psychiatry commits. So I started this thing and I thought, the challenge is going to be to get people willing to be part of it. It turns out I don't think it's going to be the case. We have, from a patient's perspective, it's not a challenge anymore. There's more people looking for that, for actually something meaningful that, celebrates what a human being is, versus, well, here's what you take to stay put and keep living the life you're living, right? No, people are ready for that. I thought the challenge would be to find professionals. And, I've received a few contacts over the past months, and I say, okay, this is the time. And so I started to bring people on board very slowly, credentialing is all. What I expect to do with it is, I expect that people will join this cooperative, that they will find a profession that is gratifying as I find it now. I have a census of patients that I love. It's a very plastic census, because one thing that happens when you don't prescribe patients too much or not at all is that they don't chronify. They come and go as they need. And, because exactly, the goal is to make myself unnecessary, and it works like that, So people say, what is your census? I say, I have no freaking idea. Is this the people that are active right now that I see fairly frequently, right? So people are reaching me to join. The task is teaching. It's still a difficult task to teach the paradigm, because it contrasts with years of training that people have. But it's doable, it's feasible, and I'm doing it. And so my hope is that folks will have a lot of fun, feel they're actually helping people without hurting them, and that they will contribute. They'll say, hey, I have this idea. How do you think this style of practice fits here? Or I thought of this paradigm for psychiatry, and I disagree with you, and I want to write about this paradigm. Now, I'm not smart enough to be compared to a guy like Freud or something, but Freud had Jung disagreeing with him in real time and coming up with amazing contributions that Freud didn't, and Freud is freaking amazing. So what I'm hoping is that people reach and say, I have this thought, and I don't agree with what you're saying. I think this, and comes up with his paradigm. But I believe in one truth. But the truth is so complex and so layered that we don't reach the truth. So truth for us is a way, is a path towards truth. And some of us make a life out of that path towards truth. So what I expect is richness. I expect fun. I expect being confronted and questioned and learn, because the human experience is way too rich to be reduced to this thing that we have been reducing. Human beings are absolutely amazing, man. We're capable of unspeakable things. And there's much more room for positivity than anything else in our existence, and that's my hope, that it causes enough noise that I can learn more from it, and, that people join and say, boy, I'm having fun as well now with my profession.
Hear, hear. Last question. What would you say to a young psychiatrist who's just getting out of residency, who is perhaps questioning some of what they've been taught, but is a little too scared to express what they're feeling and doesn't quite know how to practice in the way that they think they should? What would you say to a young doctor in this day and age?
I would say, don't let the feeling die. You may be the next big step in this stair towards a better psychiatry. Your ideas will be. Accept the fact that human beings are too complex to fit uniformly simple models, even though I believe we need simple models to replace the one we have, or to be alternatives, like different paradigms that are simple enough to be taught. Don't quit that feeling. However, learn legalities. Learn the relationship between psychiatry and the law. because once you are strong in that position, you can actually say, all right, I'm going this direction and I'm going safely in that direction, because I would not advise anyone to ruin your career on account of that kind of pressure. If you need to fall back to standard, you fall back to standard. Do not sacrifice your career because you need to live to fight another day. But, good things are coming. Great changes are coming. We have hallmark publications. We have the Maudsley de-prescribing guidelines to prove my point. We have Bill Maker and Lichtenberg book to prove my point. We have the fact that I've been practicing psychiatry in a completely different way, and my phone didn't ring yet with threats or anything like that. It's a changing, exciting time, and we will be rich again. We will be a field that is as rich as psychology used to be again. It's unavoidable because the truth always makes itself noticed.
Fantastic. So where can people find you if they want to reach out?
They can find me. Oh my God! They can find me on my page, the network page. You can find it's www.truepsychiatrynetwork.org. You're going to find an email there. You're going to find a phone number. You can call, leave a message, text, whatever you want to do, to discuss ideas, to talk in my podcast, whatever you want to do, to join the network. The only limitation to the speed of people joining the network is the finances involved in it. It has a cost until it becomes self-sustainable. I learned a lot from a lot of people, so feel free to reach me.
Well, Dr. Nardi, thank you so much for being here with us and for sharing your new paradigm and helping move this world forward. I know people like me really appreciate it, so I'm glad you're doing the work.
And I appreciate you. It's very good to see you again, Brooke.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.